So yeah, I worked at Trivago for 8 years, and I've been at CCP now for the last 2. And what I'd like to share today are, in some sense, some of the lessons that I've learned, some of the experiences that I've had doing this kind of work with technology and development over the last 10 years. I actually gave a presentation, I think it was maybe I'm looking at you guys, but I'm not sure that either of you were here. Beth, you may have been here. I think it was the first year of the seminar series. Yeah, was it that?
2010 or 2011.
Yeah, so it was a while ago.
Yeah.
And I did something actually kind of similar, again, where I sort of shared lessons learned, but I thought I would do a bit of a reprising of that, and maybe some updating. And I thought I'd frame them. It's more fun to talk about myths than it is lessons learned. So I sort of flipped them on their heads to make them perhaps a little more contentious. I'm not sure if they will be. I'm not entirely sure that I completely believe that all of these are myths or believe what I've written. There may be some hyperbole involved, and in some sense, it's just to have fun and stimulate some thinking and some conversation. And that just the last thing I'll mention, again, this is really based on my experience having done this kind of work, again, in limited resource settings. So it's more from a practice perspective than, say, a research perspective. I will talk a little bit about research, but this is really about sort of what happens on the ground in these kinds of environments when you try to do this kind of work. So with that, I'm going to go ahead and get started. And I've kind of grouped these myths into different categories. So I'm going to start talking about evidence. So here's myth number 1. It's too bad Alan isn't here.
That's really...
This is, again, there's some levity maybe here. So I'm just having some fun. So I remember back, this is similar to the first slide that I used in my presentation a few years ago, and Alan was sitting right up in the front, and he just about fell out of his seat. He was thinking to himself, how could you possibly come here, especially at a research institution like Hopkins, and say evidence isn't important? So this is a sort of, let me explain. So again, I'm coming at this from a practice perspective. So the question is, what is important when you actually come to the point of implementing a project? And the reality is that sort of, despite calls for evidence-based approaches, and perhaps despite our best intentions in terms of building the evidence base, in some ways the march of mHealth has continued for years, despite there being what may or may not be a lack of evidence for mHealth. So again, from the perspective of practice, evidence is not a huge barrier. From my experience, country governments, more so now than ever, are interested in mHealth and looking for guidance and support on how to develop strategies, how to implement projects, etc. Our requests for award and proposals coming out from USAID and other donors continue to include in them requests for innovation, and oftentimes call out ICTs or mHealth in particular. So there's constant requests for mHealth. So again, from the perspective of actually doing mHealth, it's not like the potential lack of evidence is seen as a huge barrier. And even in countries where they sort of put the brakes a bit on mHealth. So I'll give you an example. When I was giving this presentation last time, I had recently, at that point, I was supposed to have gone to Uganda just a few weeks before that, or a few months before that. My trip got canceled because the Ministry of Health put a moratorium, essentially, on new mHealth projects. But as I was thinking back to that experience in preparation for this, what I remember from that moratorium was that it wasn't, they weren't saying we want to stop all of these mHealth pilots because there's no evidence. They wanted to just kind of get some control over all of this proliferation of projects that were happening in the country. So it was more about trying to bring some coordination and some coherence to the mHealth initiatives in the country was not because of evidence. And also another part of that was that they wanted to really look at how we can start to integrate these initiatives and make them work together, make sure they're complementary, make sure we're not duplicating efforts, and make sure that, for example, any data coming out of them gets integrated with the district health information system. So again, it wasn't about evidence in that case. It was really just about making sure that there was some coherent approach going forward and some coordination of all of the mHealth initiatives. So again, in some sense, it's a bit of a stretch, or it's very specific to a particular context, that of practice and implementation of mHealth. But again, it's not evidence necessarily that are stopping new projects from occurring. Sure.
I don't know if you were done with.
Yeah, that's. I'm ready to move on.
Okay.
Yeah.
My name is Jess. I've been working as a consultant for Garrett Mel.
Sure.
I'm working with Alan as well. Working particularly on scaling up mHealth, and so evidence actually comes up a lot. So, I mean, I agree and I disagree with what you're saying in terms of implementation, maybe getting funding from USAID for a pilot or a proof of concept for a couple of years, maybe there doesn't need to be that much evidence. But when you actually talk to people at the Ministry of Health and talk about what it would take for them to take their scarce resources away from something that is proven and put it into mHealth, I think evidence is critical.
Yeah, I would completely agree, and I may touch on a few of the good points that you just raised in some of my other myths.
Okay.
I think there are some situations perhaps in which even that challenge isn't as much of a challenge, this sort of establishing the cost effectiveness of a specific project or intervention. But again, great points, and we'll see if maybe I touch upon some things that are relevant to that point.
Yeah,
if
I don't know. Maybe you
I'll,
have some experience. Like, I'd be curious to know if you have experience kind of trying to integrate things or speaking with people at the ministry where they have enough like faith or excitement in this new topic that they don't need the evidence.
Yeah.
But I just haven't come across it.
Yeah. Okay, so yeah, I will definitely touch upon some of that later. So if I don't, remind me.
Okay.
So related to that first point, I think there's a second myth, which is there is no evidence. And again, there have been calls for more evidence for years, ever since I can recall, mHealth kind of being a thing, in fact. It's a bit of a mantra. Every mHealth summit, there was always this call, where's the evidence? In working with Garrett and Alan and others,
Yeah.
You probably hear that same call. But actually there is a lot of evidence out there, if you know sort of where to look and how to look. So just as an example, at CCP about a year ago, we developed something, a site called mHealth Evidence, which is anyone ever heard of or been to mHealth Evidence? All right. So mHealth, the whole purpose of mHealth Evidence is to create sort of one place where we can start to bring together the world's evidence for mHealth. In that one site alone, we currently are indexing almost 6,000 records that come directly from peer-reviewed journal articles. So there are literally thousands of articles, 6,000 in fact, on mHealth. There is in fact a wealth of evidence out there about mHealth. Now, that being said, all evidence, I guess, in some sense isn't created equal. And it's certainly the case that some of the sources of evidence in there are perhaps not as rigorous as we would like them to be. But even then, even if we said, well, maybe half of them aren't as rigorous, that still leaves us with several thousand articles as a pretty strong evidence base for different types of mHealth interventions. I think in some sense, not to suggest we don't need more evidence, but some of the things that we really need, I think now, are more sort of analysis and synthesis of that existing evidence base to start identifying some of those sort of promising practices or best practices. We've seen a few syntheses done, but I think there is a great opportunity here to do more of that kind of work. The other thing too around evidence, where there is definitely a gap in terms of existing evidence, would be around issues of cost and cost effectiveness. So when it comes to ministries of health, as you rightly pointed out, they're looking at not just is this sort of mHealth intervention efficacious, but is it effective, and most importantly, is it cost effective? So I would agree that in that sort of area of evidence, there's a lot that could be done. But there's also a lot that we know about, again, sort of the efficaciousness or the efficacy of certain types of interventions. And also we know a lot about sort of operations research and sort of how best to go about implementing projects. There's a lot of evidence out there, a lot of experience that's been shared that we can tap into. So again, a lot of evidence out there already. We just need to do a better job of kind of wrangling it, synthesizing it, and filling in those gaps where they do exist. Okay, so moving on from evidence to pilots. So you used the word pilot before, so I'm going to talk a little bit about my experience with pilots. So myth number 3, there are too many pilots. So I don't know when the term pilotitis was developed or whatever, several years ago. In fact, I think when I did my presentation last time, pilotitis was a thing that everybody was talking about. But I was not convinced then, and I'm still not convinced 4 years later, that we do have too many pilots. This is a qualified statement like everything else. I think if a pilot is done for the right reasons, that is to learn something, then there's nothing wrong with doing a pilot. In fact, that's how we sort of talk about research, right? What's the purpose of research? Is to learn something. So as long as the pilot is done for the right reasons, I don't think there's any major issue with it. This is something that, in the business world, they test things out all the time, right, to improve their products as they go along. Again, the whole purpose is that you're learning. In any sector, this sort of thing happens. In education, they're always trying things in the classroom, tweaking things, capturing data and seeing what works and what doesn't. I think there's still a lot of room to learn new things. So I'm not convinced that there are too many pilots. But again, qualified statement here, if you're going to do a pilot, make sure you're doing it for the right reasons. If there's already evidence out there and lessons learned, don't go trying to recreate that. Build on what we already know works. Do a pilot if there's something new to be learned, or if you're implementing it in a new context and you're trying to see if something that's worked somewhere else is going to work where you are. So again, not to suggest that there isn't, going back to sort of the evidence myths, not to suggest that there isn't anything new to learn. I think there is still quite a bit to learn, so let's not dismiss the pilots just yet.
Can I ask you, so when I've looked at evidence for certain things, I see a lot of pilot studies out there. And I'm wondering if that's part of the reason that there are a lot of pilots, that the term that you mentioned was even coined, is because folks really struggle to make a business case to scale this stuff up. And that's like, so my focus is sort of domestically and looking at ways to try to move projects forward in the United States, and you got to come with a business case, and if you don't have a sound business case, then you're done. And I tend to struggling to find the evidence or the right business case around some of this stuff. So you can jump on that later, but I didn't know if that may be one of the contributing factors to this perception of pilotitis, is because pilots are usually funded based on fantasy dollars, right, by foundations and other grants and things like that, and it's all fine and well for a couple of years, and then poof, it's all gone, and reality sets in.
Yeah, I think it's another great point. Did you want to say something?
Actually, that's actually not actually the case. A lot of pilots are funded because mHealth research is expensive. The fact is that to take like an NIH grant that you could do, like an R21, for example, which is about $250,000. You have to remember that when you do mHealth research, you have to get the cost of the phones, the data plans. You have to determine if you can afford all the phones for all the people you want to do. You use, and you're following them however long you're following them, and you're remunerating them, so you're adding this extra cost you're carrying extra costs in this study that you wouldn't have typically carried. And that is why they end up being pilots, because they end up having small numbers. You can do a bigger study you can do like an RCT, but it's hard to do it. You wouldn't do them with 30 per arm. It's just very rare you wouldn't see that. So studies end up being pilots because they have 100 people in them, and then you just want to see if someone can physically use the phone, if they understand how to use the phone, if you can get, what can you get from using the phone. And there's a lot of different types of groups of individuals that people study, and so it's different for every group of individuals. So you might be dealing with youth, or you might be dealing with elderly, and so that people don't really know. We don't have a lot of we haven't worked with phones with those, or if we're talking phones, there are other things we could be using. But I think that's a big reason why we still have feasibility studies, is that...
It's still a tougher business case, though, right? I mean, it kind of boils down to the dollars and cents of it. I mean, research is a business, so there's a business case that you have to...
Right, and I think that, and it's also really, really risky, and I think that funding something that is like, it would need to be considered high risk, high reward, and I don't know if we've shown that there is high reward. I mean, I think personally there is, but I just not everyone's bought into it.
Okay.
But really, research in general is expensive,
right?
Whether it's mHealth research or not. But
right.
a really good point. And I may touch on a few things with regard to sort of business cases momentarily. So again, I'll say the same thing. If I don't quite hit everything, let me know, and we can continue talking about it. So this myth here is maybe a little. It's sort of a corollary, perhaps, to the last one. Again, if the point is to learn something in a pilot, you may learn that what you're trying to do actually doesn't work or isn't a good idea, and therefore it should die. Not all research that's done leads directly into some kind of project or product or service or intervention. And the other thing too that maybe is a little difficult is just the terms themselves, scalable or scale, and sustainable. What do those even really mean? In different contexts, they can mean very different things. For example, in Malawi, if your target audience is all doctors in Malawi, you're talking about 300 people. That's scale in Malawi with doctors. If you're talking community health workers in Ethiopia, you're talking 50,000, right? A completely different scale. So the word scale means very different things depending on where you're working. And then from a sustainability perspective, I mean, what does it mean for something truly to be sustainable? And there's certainly issues of cost related to that. But I think that's maybe only one element of sustainability. There's sort of a more human kind of motivational element to sustainability. If people can afford it, if they don't want to do it, they're not going to do it. And I'll come back to talking a little bit about some of that later. So maybe financially sustainable, but it's just not, socially sustainable or something, again. So even those things are a little challenging. Oh, and the other thing I would mention with regard to sustainability, there are also differences here in terms of why you're doing your mHealth project and what is the context. So one interesting example was some work done in Haiti during, I think, Carnival. And the idea was to develop some tools that could be used to support, I think it was sort of emergency responders during the festival. So the festival only lasts, a few days, like a week or something, right? For that only needed to be sustainable for a week. That was its purpose, to be used for a very short period of time. That kind of intervention doesn't necessarily have to be around in a year from now. They might want to redo it a year from now, so it needs to be replicable in some sense, but it may not have the same requirements in terms of sustainability with something like the Mama Project in Bangladesh. Mama Project in Bangladesh, which is reaching, presumably at some point may need to be reaching millions of women and would need to be a sustained sort of thing. Women are always going to get pregnant. So that needs to be around forever? I don't know. So again, notions of time and sustainability differ from one context to another. Any questions before I move on? All right, so those are myths about pilots. Some myths about working with mobile network operators. And this is where I think I might bring in some of the other questions and ideas that have come up. Myth number 1, or number 5, I guess, at this point, but myth number 1 with regard to mobile operators, they care about your project. What do I mean by this? These are for-profit businesses, right? So what do they care about? They care about their bottom line, and that is dollars. What is most important to a mobile network operator is increasing what they refer to as average revenue per user. That's basically the amount of money each individual mobile network subscriber spends, on a monthly basis, for example. Sometimes they refer to it as ARPU. There was actually a really great report recently from the GSMA where they did some sort of a survey of many different mobile network operators and sort of asked them about what was most important vis-a-vis sort of mobile for development work. And a majority of them came back with does it increase our revenue per user? That's what's most important when we're developing these sort of what they would refer to as value-added services, or things that kind of ride on top of their network. So that's one thing, ARPU, right? Revenue, money. The other thing is these are companies that have literally millions of customers. Tens of millions of customers. And they add hundreds of thousands every quarter. So we're talking about a massive number of people that are customers of theirs, each of them generating some revenue. Imagine you come along with your project idea that's targeting 100 people or 200 people. They're going to laugh at you. Yeah. They're going to ask, how are 200 people, when we have 20 million subscribers, going to help us increase our revenue per user? To get to the business case perspective, where's the business case? How does this help us? Whether those are 100 new customers or there are 100 customers that are going to use the network more and generate more revenue, it's still a drop in the bucket when it comes to their sort of existing business. Now, if you're talking about 50,000 or 100,000 or several million people eventually using a service, that's when it starts to become really interesting. And from the point of sustainability, you could potentially look at developing some sustainable interventions and business models at that scale. And they'll be willing to work with you when you're potentially going to bring them numbers like that. This is a scenario in which the evidence base, especially for cost effectiveness, may not be as much of an issue. If you come to the table with a mobile network operator in a financially sustainable business model, there may be a lot more support for looking at scaling up your intervention than if you didn't have evidence. And the one thing that I'm thinking about in particular is a project, a BBC Media Action project in India called Mobile Academy, which is very simple sort of distance education sort of intervention where community health workers can sign up for a service, they call in and they listen to audio recordings that are essentially lessons, right? And then there's a whole series of lessons. When you finish, you can get a certification that you finished, et cetera, et cetera. What's particularly interesting about that one is that there was a lot of negotiation and work with the mobile network operators on developing a business model whereby community health workers would actually pay for everything themselves. They were able to negotiate a very small rate for airtime for community health workers that would enroll in this service, low enough that community health workers could in fact afford it on their own with their own salaries. And the mobile network operators could make some money doing it. And there's something like 250,000 potential sort of community level health workers that might want to enroll in this. So we're talking serious money. So the government sees that and says, yeah, let's scale this thing up. We want to bring all of our community health workers onto this mobile academy. So if you can make the business case, sometimes you can kind of skirt around issues of
What's the incentive for the community health worker that has to pay?
there's a few things. One is potentially just to do a good job. Two is to get a certification that says you actually know what you're doing, and you can then use that to shop around for other purposes. Those are just the two that immediately come to mind. But and $1.50 is $1.50, right? Did I say that? I mean, ultimately, the total cost we're looking at is basically $1.50. It's a very low cost. But again, if you're talking at a scale of hundreds of thousands, that becomes pretty impressive. So again, don't necessarily go into your project thinking that the mobile operators are going to care. You have to realize kind of the context they're working in and the perspective they're coming from when thinking about that. The other experience I've had is that, and for those of you who aren't familiar with the abbreviation there, CSR is corporate social responsibility, sort of the do-gooder arm of a for-profit organization, where they take some percentage of their profits and put them towards projects for good. They want to show that they're good corporate citizens, that they're also helping out and making a difference in the world. So, I just thinking back, 5-7 years ago, people were always talking about going to the CSR department of mobile network operators to look at ways that they could potentially provide support, including things like discounted rates and all that sort of stuff. But the reality is that isn't really a very effective model or approach. It's worked for some, but in most cases, mobile network operators really aren't interested. The CSR departments aren't necessarily interested in supporting mobile projects. They're very interested in supporting kind of general health projects. So for example, I remember some experience working in Ghana with MTN, and they were really excited about what was in some ways a very traditional sort of health project, training health workers, improving quality of services, shoring up supplies and things at facilities. But they could care less about like the little mobile kind of M-learning and M-health component that we put in there. In fact, they weren't even quite sure if they wanted to fund that. In some sense, they're sort of a little hesitant to sort of mix their corporate social responsibility in with their core line of business.
Aren't there I don't know if this applies everywhere, but what I've heard is there are kind of like stipulations for CSR work that it can't directly increase like the user base or the I don't know, the gains of the MNO.
I'm doing good, but I'm really helping my bottom line type thing.
Yeah, so you have to only be involved in, I don't know, certain areas. I think outside of the CSR department, MNOs can decide to give reduced rates to try and but with a sort of benefit in mind that it makes them look good to the community. But I think the CSR isn't supposed to have that goal, right?
I think it depends country to country, provider to provider. Some do it because they don't want to, some do it perhaps because they can't do it. But I'm not aware that there's sort of a blanket law that says you can't, you can't mix your CSR with your core line of business. You see things like, Google AdWords and discounts for nonprofits, for example. But I guess that's not necessarily CSR, so it's maybe a little gray in some cases. But whether it's because of regulation or it's because they're not interested, the reality is that the CSR department is not the place you want to head if you're looking for some sort of support or looking to work with the mobile network operator. The place to go is sort of their corporate services or enterprise services or wherever the value-added services are handled, because that's where they're going to be interested in talking to you about working together. Of course, with that in mind, you have to think about myth number 5, which was they're not going to care unless you're talking about significant scale and impacting their bottom line. So don't go to CSR, go to the value-added services people, and go with a business case, prepared to speak their language, as it were. All right, moving on. Myths about technology. So myth number 7, mobile is simple and easy. And what I mean by this is that I'm thinking specifically about, when you want to do voice or SMS or USSD. I'm not talking about like mobile web or even apps to some extent. Because with the mobile web, there's already this great platform out there called the World Wide Web that is very easy to work with. It's very easy to register a domain. It's really easy to get some cloud-based hosting service. You can even build things on top of, existing platforms that like Google or Amazon provide. You can stand things up really quickly and easily, and that stuff just works. But there aren't similar tools when you want to, say, set up a voice or text service for pregnant women in a country. You can't just sit back here in Baltimore, get on your computer, and set that up from here. There are platforms that are being developed, and there are organizations that are trying to make this easier, but it's still relatively challenging, honestly, to do it, and to do it in every country. So, because the challenge here is you really need to kind of integrate with those local mobile networks to do these, again, the voice, text, USSD, the sort of non-mobile web or non-app stuff. The app stuff, basically you've got app stores and people who have smartphones can download apps, and that's not a problem. You completely bypass everything. But if you need to work with a mobile network operator, you don't have these easy tools. There are services out there, Twilio, Nexmo, I'm not sure if Clickatel is still around, that try to make essentially provisioning of a phone number on a mobile network operator's network in country, but oftentimes, that only works in certain countries, or if they have numbers in a certain country that you can use, they may only support text or they may only support voice. In fact, I was looking recently at one of these services and looking for numbers in Nigeria. For some reason, I couldn't get any numbers that could do text, but I could get a whole bunch of numbers that could do voice, that I could then use to set up my local voice service. But again, from one provider to the next, the countries that they have kind of access to changes, and even then the kinds of things you can do over those connections that they provide to you may be limited. So yeah, it's not quite as simple and easy as the web yet. Perhaps we'll get there. Perhaps when everything just goes to IP and it's all just like the web, then that won't be such an issue. But we're not there yet. Sort of in contrast to that, mHealth, myth number 8 is mHealth is hard and complicated. So while the tools and the technology that we need to use to set up these sort of things aren't particularly easy to use, the kinds of applications that we can develop once we have all that stuff in place don't necessarily need to be all that complicated and complex. In fact, going back to the broad body of evidence that we have, there are all sorts of things that we have a pretty good sense work well. Things as simple as a reminder for an appointment. We know that sending a reminder for an appointment, especially if you kind of send it within a few days of the actual appointment, can actually significantly increase attendance rates at those appointments. We know that simple point-of-care tools that can be installed on a device can in fact support clinical decision-making at the point of care and improve quality of care. We know that, for example, sending text messages to reinforce things that people have learned can in fact help do that and lead to longer-term retention of knowledge and skills, and even impact behaviors. And we know things like simple text message-based systems or even voice-based systems for reporting stock levels at facilities can in fact reduce the likelihood of stockouts of critical medicines and other supplies and commodities. But those are, or maybe one last one would be even some stuff around social media, like participating in a Facebook closed group is really effective at reaching hard to reach, most at-risk key populations. I've seen some interesting work done with HIV, for example, men who have sex with men, and using closed Facebook groups to provide psychosocial support to them. So these kind of things aren't really particularly complicated, and they can have really significant impacts. While the technology isn't always so easy, what you build on top of that doesn't necessarily have to be incredibly complex. All right, so I think I'm in the home stretch here with some myths about impact of mHealth. Myth number 9, mHealth affects health outcomes. Again, there's a little bit of hyperbole here. I'll explain why. I'm not entirely sure that mHealth is a health intervention. And why do I say that? I think about Alan, who likes to talk about, mHealth overcoming health systems barriers to interventions of known efficacy. But mHealth there isn't the intervention, right? The intervention of interest is antenatal care, for example, or it's the use of misoprostol or something like this. What mHealth does is it overcomes those barriers on the way to getting to that. So it doesn't directly affect. It's not exactly a health intervention. It doesn't directly affect the health outcome. In some sense, the thing on the other side of the barrier is the health intervention and what has the outcome. You're helping get over that barrier. In our world at CCP, in terms of behavior change, I'm going to take a slight detour here, but I promise I'll come back. There is a model that we use to inform a lot of our work. It's called the ideational framework is sort of how we refer to it. In some ways, it's a framework that brings together many different behavior change and behavioral theories and models, reasoned action, extended parallel processing, et cetera, into sort of one thing. And there are then several types of ideational factors, all which affect behavior. There are sort of cognitive factors, emotional factors, social factors, knowledge, attitudes, self-efficacy, social norms, these sorts of things, right? And all of these things, we say, affect behavior. In fact, they don't affect behavior. They affect, that's funny. They affect one's intention to do a behavior, right? But keep that in mind. Ideational factors, intention, behavior. Where does mHealth come to play then in that? mHealth can potentially affect those ideational factors, one's self-efficacy, one's knowledge about something, one's beliefs or values or attitudes about something. But again, in that case then, you've got mHealth over here, you've got a bunch of stuff in between, and you've got behavior at the other end. So again, mHealth is not directly affecting and having an impact on the ultimate outcome of interest, which in this case would be behavior. It's distal. It can be, in fact, quite removed from the ultimate health outcome that you're looking for. I think to some extent, if that is in fact the case, that has potentially some important implications for how we monitor and evaluate.
We have a question from the web.
Oh, yeah.
So, would you still group decision support mHealth solutions under this myth?
That's really interesting. I'm in my mind. I'm trying to imagine who it might be that's asking that question. I bet you I could guess. Would I put decision support under here? That's a really good question, and I think I still would, and I'll tell you why. Because what do decision support tools do? They help clinicians make decisions about then which interventions to apply. So the decision isn't the intervention, right? The intervention is whatever comes after making the good decision. So that's just my quick initial thought on that. But I would suggest that in this case, decision support tools don't directly affect health outcomes. Again, so to the point about, I think this has potentially implications for how we evaluate mHealth. I think in that case, what are you looking at primarily? Does the decision support tool help providers make good and better decisions? That's where you need to be looking. That's the immediate effect of that tool. Now, we assume, and probably have evidence from elsewhere, that if you make better decisions, then that leads to better interventions, which leads to better health. So hopefully a lot of the evidence for kind of what comes after the mHealth intervention already exists. And in the behavior change example, there's a lot of evidence out there to show that, for example, increasing self-efficacy increases intention, right, to do a certain behavior. So what should we potentially be looking at? Does an mHealth intervention increase self-efficacy? That should be our question. Not does it lead to some behavior change. Now we can look at that long path, right? And we can connect some dots, and not to suggest that in our research we're not also looking at behaviors, or we're not looking at, ultimate health outcomes. But in some ways it almost seems somehow unfair to me to be asking the technology to have direct effects on health outcomes, because it doesn't. These are information and communication technologies. They're not drugs, It's not a syringe, They're somehow distanced from what is actually creating the health outcome. That would be my answer to that question.
Thank you.
Any other thoughts? All right.
So then I guess I'm just trying to figure out like the path. So then if you've got a proven healthcare intervention, and a known barrier, and you can prove that mHealth gets around that barrier or removes that barrier somehow, then that's the win, right?
That's what I would think is the win.
Yeah.
All right. That's good. That's maybe an easier and more clear way of putting it. I think that's really as much as we can do with the technology. We should not be trying to say too much. That's when we get into trouble, I think. And again, there hopefully is evidence of the efficacy of the actual intervention we're trying to remove the barrier to. Right? Again, like antenatal care. 4 antenatal care visits, improved health outcomes, awesome. So we should be trying to improve the likelihood that a woman attends all 4 antenatal care visits. End of story. Or, anyway, not to belabor the point, but I think you get me. And the last one is that, the last myth is that mHealth is a tool that will essentially help us to reach everyone. And I'm not suggesting that people necessarily think this, but there is a little bit of sort of silver bulletness about mHealth, and it's the thing that's going to fix all of the world's ills. And in some sense, I think the near ubiquity of mobile technology sort of lulls us into this state where we think again that we can in fact reach everyone. So the reality, though, is that there are still sort of significant gaps in many different areas. Even so, from sort of an access and ownership perspective, even if you just look at the top line sort of national level numbers in many of the countries we work in, it could be anywhere from 10% of penetration at the population level to higher. Some places 45%, place like Liberia 55%, and higher. So just from that perspective, there are certainly gaps in ownership. Not everybody has a mobile phone. And then looking at gender, for example, we know that there is a relatively significant gender gap in terms of the ownership among men versus the ownership among women. The M Women Group did some research several years ago. I think they found something like a 20% ownership gap between men and women. That may have closed since then, because I know they are actually doing a lot of work to try to close that gap, but that gap is a reality. There are literacy challenges, of course. There are ways to maybe address that, using more visual methods, images, or even audio, other things that don't rely necessarily on reading text. But literacy oftentimes is a challenge, and maybe not even just sort of literacy, but health literacy as well. That's also a big challenge. And digital literacy, in some sense, is a challenge. The other thing that I think is a challenge, maybe that doesn't get as much play, but is the one that's sort of about motivation and one's interest and willingness to do something. So I sort of talked about this earlier, but just because somebody has the device or the gadget or the technology can use the device, but doesn't necessarily mean they want to use your mHealth application or participate in your mHealth project. So you kind of need to have a constellation of things, access to the technology, ability to use the technology, and the desire and motivation to do so. If you've got all those things lined up, then chances are you'll be pretty successful. And actually, I have this sense that perhaps it's a lack of that sort of constellation of factors that leads sometimes to the less than stellar outcomes to some of our projects and research, honestly. Because it almost seems to me that very few projects show no impact. There's always some level of effect. And so that can be for various reasons. But I don't know that there's oftentimes a direct sort of look at the motivational factors, the behavioral factors behind these kinds of interventions and applications. And I would bet, I don't know honestly, but I would bet if we dug into that a bit, we would find that some of the lack of success, or perhaps not the lack of success, but the limited success of some of our work is due more to those human factors than it is to other factors. I'm not going to belabor that. Some folks had to step out. It's after 1 o'clock. But I do, so I wanted to end with 10 myths, because I thought it was a nice round number. But I actually do have one more myth. I apologize, it's the last one, but this is one that I'm particularly interested in, and that is sort of a myth around local capacity. And by this I mean technological capacity. The reality is that there is a wealth of capacity out there. In fact, before I came, I took a quick look at this map of innovation hubs across Africa. So I hadn't looked at this in a while, but I looked this morning and there were 108 tech hubs, business incubators, university labs, and hacker spaces all mapped out on this map of Africa. So and I'm sure there are many more that aren't even on there. Of course, Africa is a big place, but I guess that means there's roughly 2 of these for every country. And in some countries, of course, there are more. So that's one thing. I also was recently in Indonesia where we were doing work to develop a smartphone app. The reason I was there was to interview potential local technology partners. We interviewed 9 firms, several more have sort of come in since then, and they were all very strong candidates. And they all came from just the Jakarta area, and we spent like a few days trying to figure out who might be, potential partners. So we didn't even put all that much effort into doing it, and suddenly these 9 different groups showed up. And I've had experiences like this in many other countries, even going back as far as my very, very first work almost 10 years ago in Mozambique, where we developed the Ministry of Health's training information system, and we did it working with a local technology partner there in Mozambique. That was 2005. Today, actually, that system has scaled nationally, and it's still around, it is sustainable, in fact, which is great, and it has scaled. But again, the point is, there's a lot of capacity out there, a lot of smart folks on the ground who can help us build things and implement things and support things. So we shouldn't necessarily think that we have to be the ones coming up with all the great ideas and building all of the gadgets, because there's some real significant capacity out there. So that's the last one. Thank you for those of you who stuck around. Thanks to folks online and to some of those good questions. These are some of the myths as I see it. Again, maybe a few of them were a little hyperbolic, but it's fun just to kind of throw them out there and have a conversation. Thanks to Yorgos for setting everything up. It's unfortunate the dynamic duo of Alan and Larry, neither of them could be here today, but maybe they'll watch the recording later and they can come scream at me down in the Inner Harbor for some of the things I've said. Anyway, hope you enjoyed that, learned a thing or two, and free to take any questions here or later. So, thanks.
Did we have any questions? I don't want anyone leaving without getting the question.
The question is there more pizza left?
There's more pizza.
Can you talk a little bit about, so it sounds like most of your experience is ex-US.
All.
Okay.
Well, all of this kind of experience.
So what about getting things done here locally, like East Baltimore, or just
From which perspective?
Just any of these projects, like I've hit some brick walls, trying to get things up and running. It seems like it's, I mean, to your point, like it's expensive.
So I did my entire PhD was an mHealth project in East Baltimore.
Oh,
Yeah.
awesome.
It was using Hopkins platform eMocha. Have you heard of it?
Yeah.
And looking at the drug using environment of injection drug users of the ALIVE study to better understand the drug using environment, to understand when drug craving and drug use occurs. So we can sort of intervene at different points to understand how we can prevent relapse and HIV infections. So we used a different method, another mHealth sort of method of data collection known as ecological momentary assessment, which sort of shortened the time that we needed to see individuals by giving. So eMocha was actually started to be on the platform for community health workers to go into the field. And we turned it around and gave the phone to the drug users to tell us each and every time they craved and used drugs, so we could understand what was going on around them, and then subsequently ask them other questions along the way.
So you had success in partnering with existing, like...
So we had success because, we partnered, so we nested within an existing, so mine was a feasibility study, so we nested within an existing large cohort here at Hopkins of chronic drug users who are, one, they are very used to, complying, and they get remunerated, and they're sort of, but they're older, and we weren't sure how they would be able to use the device. A lot of them didn't have smartphones. A lot of them had just sort of flip phones. They didn't, we weren't sure if people were going to steal the devices. We weren't sure if people were going to actually use the devices. And surprisingly, they didn't sell them. We lost one person who was arrested, so we got that back, thankfully. And then another person we did ask to leave because they basically broke 2 phones. So we had 2 in or out. But I'm also working on a separate study with someone else in HBS that's giving young men that have sex with men phones to look at their sexual risk behaviors and associated with drinking. So the event of interest we're looking at is sort of the drinking episodes, and then what kind of risky sex they engage in for their risk for HIV infection as well. And what's interesting is that these men are not really apt and interested in using the phones because they already have smartphones.
Yeah.
And they don't want to carry 2 phones.
Yeah. That I think is a really important point.
Right.
The better you can do it at designing your intervention so that your target audience already owns the device.
Yeah.
You're going to save a lot of money potentially.
Well, that too, and you save a lot of money. You don't have to worry about and then we had all the issues with our devices was that you have studies that take a little bit of time. You stagger entry. We didn't have so many phones. We had to stagger when we gave people the phones and how many we had out at once, and so it took a while to get. We only had 109 people in the end. It took us 3 years. I mean, it took us a long time. Part of it was we had at one point we had to buy totally new phones because they were just getting outdated and they were just beat up.
Yeah.
So and eMocha, for whatever reason, eMocha can't be well, it doesn't work on iPhones, which a lot of people have, and we weren't installing it on people's individual Android phones. People were saying they were using data and they're using airtime. How do we, take care of that? We couldn't pay for that for the participant. If it was our phone, anything that they used on the phone, we paid for. So it was a lot of trial and error, and there was some focus groups, and it's sort of it's really reaching the population you're looking at where they are. So with our drug users, surprisingly, people didn't think they would do it, and my advisor knew these people are actually very reliable. We sort of the ALIVE study has a long-standing group of people that is sort of compliant in a way with protocol. But this other one, which is, we're recruiting off the street. We're just street recruiting. It's a different sort of. These young men are just sort of not interested, and so.
I have actually a question. So you're saying that if someone brought you their phone and they, you were able to use their phone instead of buying them their own phone, so you could download the application or whatever program, that it would be too costly to do it that way instead of buying a phone?
It's not that. What got complicated was understanding how much data one would use in transmitting. It was we didn't have a lot of time, obviously, to figure out how much. We asked them we sent them 4 surveys in a day, and then they also there's a lot. We collected a lot of data, but then they responded. They prompted and told us when they used drugs. We didn't know how much all that in a day, how long it would take them to do the survey. The survey was all yes, no questions because it needs to be quick. It should take only under 3 minutes, but people thought they're not off, they fall asleep. And we weren't sure how much that was going to be.
Do you have that data from your feasibility study that you could analyze?
We could look at it currently. I think we can look at it now that we're done. That's a great question. At the time when eMocha came out, they wouldn't download it for us onto anyone's phone.
I mean, I think that would be a huge impact for the field, for people to understand if you want to collect this kind of data, this is how much it costs versus buying them their own phone. I mean, that's a huge part of why it's costly. So I think you could certainly publish that paper.
And I know there's a question on the internet, but this is one other thing that occurs to me. This is one of those places where the difference between research and practice is very stark. You know, in a practice situation, these are tools that people are using to help themselves, not tools that we are asking them to use as part of our research projects.
No, right, but I think that if you're going to scale something up, for example, like if I want to, the idea behind my dissertation eventually, like in a lofty goal, would be that if a clinician was seeing seeing a drug user that had sort of, they thought maybe wasn't ready to be on any sort of medication, say HIV medication to help their HIV infection. They weren't sure where they were. Their lives are chaotic. They have a lot going on. The idea would be the clinician to say, hey, I'm going to see what's going on for the next 3 days with you. When I send you a survey, respond. When you feel like using drugs, respond. We'll do it for 3 days. We'll look at you. We'll come back and we'll make a decision. The problem with it is if we're making them pay for that, what's the incentive for them to even, they just be like, well, they'll leave the clinic and be like, I'm not going to take HIV medication because they don't think I can get it under control. So it's hard. Like, I do actually think that it is something to think about for practice even. Like, what's going to bring the barrier down to use and engage?
Something that's of real value to them.
Yeah. So, right.
And that works on the device.
And if they're coming in anyway, if they're coming in and saying, I'm ready, that's great. We want to be able to, like, if they're ready in there, because it's hard to get people in for care for this sort of thing. Like, if they're coming in, let's do everything we can to get them, so, yeah.
What was the question?
So it's an easy one. Kate Hessel works for Planned Parenthood Global in New York, and she's looking to implement mHealth programs in Nigeria and Ecuador, and is wondering where's the best way to get in contact with CCP. We had Peter mention info@mhelp.org as a good way to connect.
Sure. That's Peter Benjamin.
Yes. Yeah. So what might be a good way for Kate to connect with?
Yeah, sure. I mean, if they're interested in connecting with CCP, they can go to our website, jhuccp.org. So it's one way, and then you can contact us through there. If you want to get in contact with me, did that come in over Twitter? Or is that part of the chat?
It's part of the chat.
Oh, okay. Because I was going to say on Twitter, I'm at JamesBT, so you can get me at JamesBT on Twitter. Or my email address is my name, James with a dot, bondtempo @jhu.edu. So you can definitely contact me that way. And I'm around in general. I'll be at the Global mHealth Forum. I'm a part of the mHealth Working Group Advisory Board, so very engaged in all mHealth Working Group related activities. So.
You're on the steering committee?
Yes. I'm on the steering committee for the GmI. There are any number of ways you can find me. I'm around.
Great, thank you.
Yeah. Awesome.
Well, thank you.
Thanks for coming.
Thank you, everybody.